Okay, so for slide 2, we have some of the pharmacology aspects of itraconazole and posaconazole I wanted to share with everybody. Itraconazole is a CYP3A4 substrate, and it's metabolized to hydroxy itraconazole, keto itraconazole, and N-desalkyl itraconazole as the 3 main metabolites. But the most important metabolite is the hydroxy itraconazole. It's similar in antifungal activity to the itraconazole parent drug, but it has 2 to 3 times higher plasma concentrations at steady state than itraconazole. So it's one of the main metabolites that's very important for clinicians to measure. And actually, if you look at some of the laboratory testing for itraconazole, it is included with itraconazole as part of the therapeutic drug monitoring. So itraconazole, as many people would know, it is a strong inhibitor of CYP3A4, but also P-glycoprotein. And what's important about itraconazole in terms of timing with other medications and drug-drug interactions is that the absorptions increase by high-fat meals and a low stomach pH. So, you know, this drug really should be given with respect to meals. It should be given with a meal or after a meal. And with a low stomach pH, it's very important to keep in mind any kind of drugs that can increase the pH. So, calcium carbonate or other antacids and PPIs, H2 blockers, those can all decrease the absorption of itraconazole. The steady states reached about after 4 to 7 days after initiation. And for our particular case, our patient has blastomycosis, so I wanted to really focus in on the specific dosing for the treatment of blastomycosis. And it's 200 milligrams 3 times a day for 3 days as a loading dose. And then it's 200 milligrams daily or BID, depending on how severe the infection is, from the mild to moderate range. But if the patient has moderately severe or severe blastomycosis, then it's twice a day. So just to clarify again, 200 milligrams twice a day for that severe type of infection. Now, the trough goal, oftentimes you'll see it being quoted as itraconazole plus hydroxyitraconazole as the total sum of those should be greater than 1.0 micrograms per ml. For posaconazole, it's a little bit different. This drug is a UGT1A4 substrate, but like itraconazole, it is still a strong inhibitor of CYP3A4 and P-glycoprotein. So there are some differences with regards to drug interactions, and some clinicians may favor the posaconazole because of this. It's a little less complicated. The steady states reached after about 6 days after initiation. And so that's when it's a good time to check levels if needed. And for blastomycosis, the dosing specifically for posaconazole with the delayed release tablet is 400 milligrams twice a day. Now, the trough level has varied a little bit depending on what type of infection it is, but for blastomycosis and for other types of more serious infections, a conservative trough level that has been suggested is 1250 nanograms per ml. And of course, that can be raised or lowered based on clinical judgment, depending on really the infection characteristics. So if you have a more severe infection, if you're trying to penetrate into different areas of the body, the brain, different organs, that might change a little bit. But for now, this is really the accepted trough level. Now for CYP3A4 and CYP3A5, I really wanted to talk a little bit more about this because itraconazole is metabolized by CYP3A4. But what about CYP3A5? You know, we hear so much about CYP3A4, but for CYP3A5, it is structurally related to CYP3A4. And there's some overlapping substrate specificity, and it can vary greatly between drug to drug. But a lot of the substrates or drugs, they do favor CYP3A4 over CYP3A5, but there are some exceptions. So 2 of the exceptions noted are vincristine and tacrolimus. So then to think about itraconazole and CYP3A5 and polymorphism within that, it's really important to think about really any studies. And there's a study that looked at CYP3A5 expressors and the drug interaction between midazolam and itraconazole. So what this study found was that the CYP3A5 expressors, meaning the intermediate metabolizers and normal metabolizers, which they do have a CYP3A5 enzyme that's being produced, they require higher levels of itraconazole to inhibit midazolam. So it was pretty interesting in this regard because, you know, you would think that itraconazole would just be metabolized by CYP3A4 and it's going to inhibit CYP3A4, but perhaps because midazolam was already being metabolized faster by CYP3A5, perhaps then itraconazole, in order to kind of slow down that metabolism, you needed more itraconazole, and that made sense. But what about itraconazole being affected by CYP3A5 polymorphisms? Could it also be that if itraconazole is also metabolized by CYP3A5 to some degree, would the levels go down for itraconazole if a patient is a CYP3A5 expressor? So this is all going to lead into the case which Serena will describe later, but I wanted to really give some of this background information about the current studies, and that was really about it with regards to CYP3A5 and itraconazole, as well as CYP3A4. So really not a lot out there. So in order to try to understand a little bit better about these types of situations where you're faced with a drug-gene interaction and you have kind of this need to understand what's going on, and there's no guidelines and there's very few literature out there, it's important to know a lot about the foundation and the basics first, so that you can kind of have the best clinical judgment possible. So it is good to understand what kind of CYP3A5 polymorphisms are out there. And in general, it's important to note that for the poor metabolizers, that seems to be the most common phenotype in which the drugs are dosing is based off of. And you can look here that there's quite a variety in the percent of patients that are poor metabolizers within the different biogeographical groups. So this comes from CPIC, and CPIC has these additional tables which are really helpful to understand a little bit more. And so in this percentage, you can see, for example, in the African American / Afro-Caribbean biogeographical group, you have around 30% of patients who are the poor metabolizers, about 21% are normal metabolizers, and about 50% are intermediate metabolizers. So overall, you have more patients who express CYP3A5 than who don't express CYP3A5. And then, for example, if you shift over to the European population, then you have about 85% or so that are poor metabolizers, whereas about only perhaps 14 or so % express CYP3A5. And so this is quite different in the different biogeographical groups. So I think it's important to note the variety. However, for CYP3A4, the polymorphisms are largely uncommon, and it's pretty rare. Now I want to shift over into CYP3A4 inhibition and induction, because of course it's important to understand the duration of how long CYP3A4 inhibition and induction can occur when you're considering drug interactions. So with itraconazole, we know it's an inhibitor of CYP3A4, and we know that also posaconazole is as well, but itraconazole is also a substrate of CYP3A4, so we have to understand the effect of other inhibitors and inducers on itraconazole when we're trying to evaluate it. So thinking about inhibition now, grapefruit is well known to be an inhibitor of CYP3A4. And some people might wonder, well, how long does that take effect? How long does inhibition take effect for CYP3A4 in general? Well, there's a study that looked at grapefruit inhibition, and you have to think about the CYP3A4 activity and its turnover. Is the inhibition a competitive and irreversible inhibition where it completely wipes out the enzyme, or is it just a competitive, reversible inhibition where, when there's a low enough concentration of the drug, then, it dissociates from the enzyme and then the enzyme is free to start metabolizing again. So for grapefruit, it's not probably as well known exactly how that inhibition occurs, but the inhibition effects do last 3 to 7 days. So the turnover rate of the CYP3A4 enzyme is a little bit different if you're looking at in vivo versus in vitro, but roughly speaking, it's probably around that 3 to 7 day mark. So this is important to consider when you're looking at inhibitors. Most people don't have this kind of guidance when you're looking at drug interactions that pop up from First Data Bank or Micromedics or UpToDate. Any of these drug resources don't really tell you how long this inhibition lasts. So this is something that is a good piece of information as pharmacists to keep in our toolbox. Now, opposite, induction, is also really important to understand too. So for CYP3A4 induction, there's a couple of mechanisms of induction, but the majority of drugs that induce CYP3A4 do it by activating the pregnein X receptor. And that causes the CYP3A4 enzyme to be produced much more than it was before. So you have a lot more production of CYP3A4 enzyme, and then you have induction of that substrate. Now for smoking, we know that smoking does induce CYP1A2, but what about CYP2D6, CYP3A4? What about these other enzymes? So there was a study of risperidone induction in smokers, and the smokers received higher doses of risperidone than the control group, which were the non-smokers, and that was statistically significant. And so we know that risperidone is metabolized by CYP2D6 and CYP3A4. CYP2D6 is really not thought to be inducible. And so the most likely mechanism is really that smoking induced CYP3A4. And there was another environmental effect model where there was twins. So they were genetically identical. And they had an induction experiment with St. John's wort. St. John's wort induces CYP3A4. The patients were all female and all Caucasian. They found that alcohol consumption, BMI, and smoking were significantly associated with induced CYP3A4 activity. So it explained about 20% of the variation. So it does appear that smoking does induce CYP3A4 to some degree, and alcohol consumption can as well. Same thing with BMI can also affect it. So what about posaconazole and UGT1A4? Well, it looks like smoking is not really an aspect that has been studied so much, and same with alcohol use. For smoking, there was just a single study that looked at multiple antidepressants, and it concluded that there was an increased dose requirement for amitriptyline and doxepin, and perhaps that's related to UGT1A4 induction. And cigarette smoking is known to increase glucuronidation, but glucuronidation of what? It's unclear if it's any of the UGTs or if it's this UGT1A4. So that's really not very clear. And for alcohol use, well, chronic ethanol feeding of rats did increase the expression of liver UGT1A1, but there's no specific data for UGT1A4 and certainly not any data in humans. So there's not a whole lot of information known about what impact smoking and alcohol use does have on UGT1A4. But I think it's really important to keep these in mind because, of course, you can run into patients who are smokers and do have a heavy alcohol use. And I think it's very important to keep in mind that impact on any kind of drug interactions with medications.